Good morning, ladies and gentlemen. A very warm welcome to the CUHK Community eHealth Care Project Symposium on the role of digital health in integrated care of older people. While you are waiting for the symposium, you may watch the slideshows prepared by the participating non-governmental organizations of the CUHK Community eHealth Care Project. The slideshows showcase the achievements and experience of the JC eHealth project from the aspects of different NGOs at their elderly centers. Please enjoy. We will starting the opening ceremony at 10:45. Good morning, ladies and gentlemen. A very warm welcome to the Jockey Cup Community eHealth Care Project Symposium on the role of digital health in integrated care of older people. While you're waiting for the symposium, you may watch the slideshows prepared by the participating non-governmental organizations of the Jockey Cup Community eHealth Care Project. The slideshows showcase the achievements and experience of the JC eHealth project from the aspect of different NGOs at their elderly centers. Please enjoy. We will be starting the opening ceremony at 10:45. Good morning, ladies and gentlemen. A very warm welcome to the ICOPE Community eHealth Care Project Symposium on the role of digital health in integrated care of older people. While you're waiting for the symposium, you may watch the slideshows prepared by the participating non-governmental organizations of the ICOPE Community eHealth Care Project. The slideshows showcase the achievements and experience of the JC eHealth project from the aspect of different NGOs at their elderly center. Please enjoy. We will be starting the opening ceremony at 10:45. at 10:45.
Repeat again, 5 minutes.
We will be starting the opening ceremony in 5 minutes. Good morning, distinguished guests, ladies and gentlemen. I welcome you to this online symposium on the role of digital health in integrated care of older people of ICOPE Community eHealth Care Project. I'm Fiona Chen, the Master of Ceremony for this symposium. Although this is an online symposium, we do hope that you could be inspired by the sharing and discussions today. Organized by the CUHK Jockey Cup Institute of Aging, this symposium has an online platform which shows the backgrounds, findings, and achievements of the Jockey Cup Community eHealthcare project, as well as the content of our today's symposium, including today's rundown and speakers' biography. You are welcome to browse on the online platform. The link of the platform is in the chat box now. Please feel free to visit online platform during breaks and after the symposium. Now, let's begin the symposium. To start with, we would like to invite Mr. Leung, Executive Director, Charities and Community, the Hong Kong Jockey Cup, to deliver an opening remarks for the symposium. Mr. Cheung, please.
Dr. Lam, distinguished guests, ladies and gentlemen, good morning. On behalf of the Hong Kong Jockey Cup Charities Trust, I welcome you to this online symposium of Jockey Cup Community eHealthcare Project. Although we're not able to meet in person, I believe it won't affect us to be inspired by many invaluable insights and sharing today. The club has long been a proponent of active aging in our community. We want older adults to maintain functional independence for as long as possible and be able to enjoy aging in place. Identifying health risk at an early stage and empowering elderly on self-health management increase the chances of making this possible. That is why the club's Charities Trust launched the Jockey Cup Community eHealthcare Project in 2016. The project is the first territory-wide elderly care support program to combine digital health management technology, community care, and professional medical support. Today, our discussions focus on the role of digital health in integrated care. We will hear about learnings and developments in this field, locally, as well as in other parts of the world, and insights into their path forward. The COVID-19 pandemic has accelerated the progress towards the adoption of digital solutions in our healthcare system. But healthcare isn't just about going to the doctors and leaving it to the professionals. Digital health technologies expand opportunities for us to be more aware of our own health, take better care of ourselves, and improve the well-being of our society as a whole. This is what the Jockey Cup Community eHealthcare Project has been empowering more people to do. Over 10,000 elderly citizens joined us in the first phase of the project, participated in well-being surveys, regular health measurements, and as individuals' health data can be uploaded instantly through the project's cloud-based eHealth platform. A more personalized telecare service was made possible. The project has proven successful in mitigating health risks from chronic conditions and comorbidities. In 2020, the project's coverage was scaled up in partnership with more NGOs and service centers to promote health awareness among another 16,000 older individuals. In this second phase, the project's cloud-based platform has connected 100 elderly centers to facilitate the development of data-driven intervention and well-being programs for elderly. In this phase, the project has also piloted a digital mode of eHealthcare in selective elderly centers, drawing insights from both health and exercise data of the elderly participants. In terms of capacity building, some 1,500 social service professionals have also been equipped with health-related knowledge. When social distancing measures tightened and elderly centers were closed amid the waves of COVID, a pilot program for home blood pressure monitoring was launched, providing an AI-enabled smartphone app that made health data uploading easy for elderly. Over 2,600 elderly have participated in this pilot program. The Jockey Cup Community eHealthcare Project reflects the club's strong commitment to the betterment of Hong Kong, in particular by encouraging socio-medical collaboration and innovative use of technology to care for our senior citizens. As one of the world's top 10 charities donors, the club is dedicated to enhancing the quality of life for people as they age in an enabling and inclusive environment and promoting physical and mental well-being. Our support is made possible through the club's unique integrated business model, through which betting and lottery revenue are returned to the community in the form of tax payments and charitable donations. In closing, I would like to express my deep gratitude to the CUHK Jockey Club Institute of Aging for organizing this symposium, the CUHK Jockey Club School of Public Health and Primary Care, and our 24 partner NGOs for their steadfast support of the project, as well as all the experts involved. I thank all of you for joining us today. I hope you find this symposium informative and thought-provoking. Thank you.
Thank you, Mr. Cheung. Next, may we invite Dr. Ching-choi, SBSJP, Chairman, Elderly Commissions, to HKSAR Government to give an officiating address. Dr. Lam, please.
Thank you very much, Leung, Professor Jin Wu, and Professor Wong, and speakers and ladies and gentlemen, good morning. And it is my great pleasure being invited to this very informative and very timely symposium on the road of digital health in integrated care of older people. And if you are in Hong Kong, you may know that we are having a lot of changes recently. In our social sector, especially for the aged care, we embrace the element of health in our service much more than 10 years ago. And I believe this kind of reform will continue to enhance further the element of health in various kind of services. And also at the same time, there is a reform in our primary care system, how to keep our population healthier, how to screen out early diseases, how to prevent various kind of chronic diseases, and better manage various kind of chronic diseases too. And at the background, we have a change of our government very soon, and we are still in the 5th wave of the COVID-19. And so actually a lot of changes are happening in Hong Kong. And I would say this symposium will be a very timely one. As far as I know, the ICOPE is one of the WHO initiative stresses the importance of comprehensive community-based approaches and introduce the intervention to prevent or delay the declining physical and mental capacities of elderly people. And recommendations include offering cognitive stimulations to elderly people with cognitive impairment and providing informal carers of elderly people with psychological intervention training and support. I was involved in the eHealth program supported by the Jockey Club and also by Chinese University of Hong Kong. And I know the emphasis is on very much on hypertension and diabetes, but actually a lot of things can be done. And I also learned that today's symposium will have a lot of discussion on medico-social collaboration. And all these topics are very close to my heart. And especially in the era where we all know that technology will be an important part of our integration and collaboration. I just take an example of dementia or early cognitive impairment. The government has supported our DECC, which is the District Elderly Community Centers, to hire more social workers, to use more Geron technology in providing support, various kind of support to the people in need, especially those with dementia. And I know a lot of these DECC actually, they employ quite a lot of technologies such as interactive IT cognitive training system, and also how to help the elderly to be more capable to age in place, especially those with dementia. Talking about this IT cognitive training system, recently I used myself as an experiment too. And I download an app in my phone and try to do my brain training exercise every day. I don't know whether it is effective or not, but I would like to see how the use of technology can help the daily life of ordinary people, not only for those with chronic disease and how to prevent the chronic disease. And I believe technology will be a very effective tool to support this kind of collaboration between the medical sector and the social sector. And talking about supporting informal carers, which is very important, and our government recognize the carers' contribution and provide quite a range of support services to enhance their caregiving capacity and reduce their stress, including counseling and training on caregiving skills. These all echo with the suggestion in ICOPE that the focus of carer support should be on optimizing their well-being and enhancing their caregiving capacity. And elderly people and carers are really at the focus of the service delivery and also the resources allocation in the coming government. And I would like to see more of this kind of initiative, especially those with more integrated care, more collaboration, because all these are the important strategies for us to face our aging population. And talking about digital technologies and Geron Tech promotion, I would say that we have talked about this for the recent years in various settings. And I hope that more technology will be employed and more elderly may be empowered to use this kind of technology. For example, the wearables, which I believe can help them in self-manage of their own health by providing reminders, tracking their physical activities, and aid the elderly to make appropriate changes to their daily routines. As the world is entering a new era of digital health, let's not forget our elderly. We should foster digital literacy in the elderly while we encourage clinicians and social service operators to leverage smart healthcare tools and use patient-generated data for care management. In the near future, digital health will enhance the delivery of healthcare, reduce overall costs, and most importantly, support the elderly living independently at home and achieve aging in place and active aging. Thank you very much, and I hope a very fruitful discussion in the various sections coming in this very timely and important symposium. Thank you again.
Thank you, Dr. Nam. We would like to invite Professor Jin Wu, Director of CUHK Jockey Cup Institute of Aging, to give an introduction on the significance of the eHealth project to community care of older people. Professor Wu, please.
Good morning. I'd like to welcome you to this symposium. Aging populations worldwide necessitate a review of how health and social care systems are designed to respond to needs of older adults. That is not just focusing on non-communicable diseases, but also targeting the aging process itself. This is driving a need to create an integrated long-term care system that covers health and social care needs in a seamless way. The World Health Organization published a framework for countries to achieve an integrated continuum of long-term care in March 2022. The continuum emphasizes coordination across health and social care sectors through seamless transition across settings, that is home-based, community, facility care, and acute care. and across various care roles in terms of prevention, rehabilitation, palliative care, and acute care in a timely manner. Care structure covers the whole spectrum from information systems to care delivery in a non-fragmented way. Services should be person-centered, optimize functional ability, and compensate for loss of intrinsic capacity over time with aging, that it can be provided in the community. And services should be integrated in the continuum and empower the older person, as well as emphasize support for carers and care workers. Now, Hong Kong has the longest life expectancy in the world. How have we responded to this? 6 years ago, the Hong Kong Jockey Club Charities Trust initiated the eHealth project based in community centers, which incorporated many of these features, which will be showcased and discussed in this conference. In the morning session, Professor Samuel Wong will set the scene about primary care in Hong Kong. Dr. Ruby Yu will summarize the essence of what the eHealth project has achieved, taking reference to the WHO long-term care model. Professor Angela Leung will talk about the ICOPE training experience in her capacity as a Deputy Director of the WHO Collaborating Center for Community Care for the WHO Western Pacific region. Various NGOs will share their experiences. Finally, we shall have a panel discussion with various stakeholders regarding the sustainability of this care model. In the afternoon, we shall listen to experiences from Singapore, China, and France about the use of digital health methods in achieving wide coverage of primary care for older people, again, followed by discussion of how Hong Kong may develop in a similar direction. And finally, Professor Martin Prince will discuss the importance of intrinsic capacity as a relevant health indicator for the older population, other than prevalence of chronic diseases. Thank you.
Thank you, Professor Wu. May we also invite Professor Samuel Y.S. Wong, Professor and Director, the Jockey Club School of Public Health and Primary Care, the Chinese University of Hong Kong, to brief us on the primary care in Hong Kong. Professor Wong, please.
Thank you for the kind introduction. Professor Jing Wu asked me to talk about primary care in Hong Kong. So I'm just going to give you a brief overview and some of the challenges of providing primary care in Hong Kong. So the first questions I have is, why do we need to care about primary care? Well, because a lot of evidence internationally shows that a good primary care system can make the overall system performance to produce better health outcomes, lower costs, and greater equity in health. But not all primary care you can consider to be able to produce all these good health outcomes with lower cost, because the definition of primary care should include good first contact, meaning the care is accessible, comprehensiveness, meaning that when the person go to access the care, there is a comprehensive provisions of services, and also coordination and continuity of care that's focused on the patient, not only about diseases, that can produce the good health outcomes with a lower cost that can contribute to overall improvement of the population health. So this is the Hong Kong healthcare system. And when you look at the primary care system, you can immediately come to understand that it is complicated. It is not something simple. But for example, in the private sector, you see a lot of the private primary care providers are providing primary care services, which contribute to about 70% of episodic care in Hong Kong. You can also look at the public system. That includes the Department of Health and also Hospital Authority, where the general outpatient clinics and also the family medicine specialist clinic, and also you can include some of the geriatric clinics that is placed under the public hospital system. Now, other primary care services that we used to call these vertical primary care services, where they are specialized primary care services, include the maternity and child care, and also some of the student health services, social hygiene services, and some of the elderly care services, which may overlap with the GOPC services and some of the private services. So in a nutshell, the Hong Kong primary care system currently is quite fragmented, and that are being provided in different sectors and often provided by different people. And this become one of the challenges, or the biggest challenges for any policymakers, to make a good primary care system that can include the 5 C's, the first contact, comprehensive, continuous, and comprehensive care that is needed to provide good population health with a reduced cost. So some of the characteristics of the Hong Kong primary care system that I believe is sometimes specific to Asia and also specific to the Hong Kong population. So we have a mixed system where the private sectors are seeing episodic care, while the more complicated people with multiple chronic conditions are being seen in the public. And in fact, people with chronic diseases, about 85% of them are being seen in the public sector, while if they become or having a common cold or something acute, they will access the private system. Although continuously, there are problems to connect the medical records between the two, especially from the public system to look at the private system, where sometimes the medications that they prescribe, etc., are not known. The public system also looking after the socially disadvantaged, older people, especially multiple chronic conditions. And although these people have, many of them have hypertension and diabetes, diabetes and hypertension are not the only diseases that these people need care from. And when you see them in person, you will know that they also have other care issues, including mental health issues, social issues, and also pain, and also frailty and other issues that are very specific to the older population that cannot be addressed by disease-focused care. Hong Kong people love to shop, and they also love to shop for doctors. So in Hong Kong, we have a very significant doctor shopping system where people who have regular source of care also are seeing other doctors for very obvious reason. For example, if they cannot be accessing the public services care, then they will look at the private practitioners to see acute care. And many or the majority of the Hong Kong population do not have a primary care doctors. A previous survey done by our team has shown that such as 60-something% of people might not have a family doctor. And we are facing an aging population where people are more and more likely to have multiple chronic conditions. From the policy or provider side, there's no compulsory training in primary care before anyone being able to provide primary care services. So anyone, including a surgeon, a cosmetic surgeon, a psychiatrist, can provide primary care without any need for doing compulsory training in family medicine or generalist care, which might also cause some of the problems in terms of continuity of care and fragmentations of care. And in fact, private providers may not have the incentive to look after continuing care because of that many of the services are paid out of services. So fee for services is the main mode of care incentive in the private sector. So we have experienced quite a number of healthcare reforms. If you want to refer to some of the earlier documents in the 1990s, in fact, the current chief executive was the secretary at that time to write this document called Health for All Way Ahead, report of the Working Party on primary healthcare, which some of the suggestion advice can still work these days. And we have healthcare reform documents being published in 2008 to 2010, including developing primary care conceptual models and clinical protocols, setting up a primary care directories, and devising feasible services models to deliver enhanced primary care services. So currently, after more than 10 years, our primary care directory has been set up, although not all the people with training in primary care can enroll in the primary care directory, but I believe more changes will be made to this directory where certain pre-assistant training is needed before they can be enrolled. And now we have the district health centers and the district Health Express, where it's the new primary care conceptual models and clinical protocols have been made for chronic diseases management that doctors are being used or are using them to look after chronic diseases management. So why there's a need to continue investing in primary care? Because we are experiencing an increasing prevalence of multimorbidity, means that primary care is the best solution to address complex healthcare needs, including medical, psychological, and sometimes social healthcare needs amongst the populations. So that's the elderly population over 65% or more will increase to 1/3 of the population by 2041. And I believe many of the health needs of these populations cannot be addressed by taking a disease-focused approach. It is also expected the current GDP on healthcare expenditure will increase, and currently is about 6.9%. And there is an expected increase of the current GDP on long-term care expenditure to 3% in 2036 from studies using the Hong Kong population projection. So what is the way forward? I understand that today's conference is on many of the outcomes and the benefits and advances in eHealth. As the Hong Kong population is aging and many people are suffering from multiple chronic conditions, I believe there is an urgent need to have a quality primary care system that has very good accessibility, coordination, comprehensiveness that can reduce the fragmentation that we currently see in the Hong Kong healthcare system. There needs to be good continuity of care such that they can reduce the doctor shopping and also the sharing of medical information such that we do not duplicate investigations and also management, which often can produce iatrogenic problems. So the hope for a good eHealth system is to, through this eHealth system that can improve accessibility, coordination, and if not in the personal continuity of care, but informational continuity of care, such that overall we can all move towards an improved and enhanced primary care system that we have been looking forward to over the past 10 years when we are expecting a good reform in primary care. So thank you very much. And I believe we are going to have a very fruitful discussion and presentations to learn about what is going on overseas and from mainland and also from the other providers and speakers locally. Thank you very much.
Thank you, Professor Wong. Next, we would like to invite Dr. Ruby Yu, Senior Research Fellows, CUHK Jockey Club Institute of Aging, the Chinese University of Hong Kong, to present her talk on medico-social integration in community care of older people, how the eHealth project has further development. Dr. Yu, please.
Thank you. Good morning. I'm Ruby. My topic today is medico-social integration in community care of older people, how the eHealth project has further development. Before I begin, I would like to thank the organizing committee to give me this opportunity to speak and share the findings of the eHealth project to all of you. Let's begin with some background information. According to the statistics released by the Census and Statistics Department, between 2019 and 2069, the number of older people aged 65 and over will more than double, jumping from 18% to 35%. This leads to the question, what are the implications of the aging population on healthcare? Using local longitudinal cohort data, we found that disability increased with age, and the increase was more prominent among the older age groups. A major implication of the increase in the number of people with disability is an escalating demand on health and social services. To address these challenges, a new paradigm is needed for elderly care, where a more prevention and empowerment approach is required. The WHO adopted a different approach to promote aging and health, where they introduced the concept of healthy aging and place emphasis on promoting or maintaining the intrinsic capacity capacity of people as they age, not only through modifying individual lifestyle behavior, but also by promoting enabling physical or social environments that facilitate functional ability, even in the presence of chronic disease and disabilities. To foster the model of healthy aging, the WHO developed the Integrated Care for Older People (ICOPE) approach in recognition of the need for the transformation of health and social care system to deliver integrated and person-centered care for older people. As well as this, the WHO published the evidence-based ICOPE guidelines to manage declines in intrinsic capacity in the community and the ICOPE implementation framework. Both documents support the implementation of the ICOPE approach in community settings with an aim to help optimize older people's intrinsic capacity and functional ability. As a public health response to aging, the Hong Kong Jockey Charity Trust has initiated to carry out a community project, Jockey Club Community eHealthcare Project in 2016. The project aims to apply digital technologies to empower older people in health management and promote integrated care and primary health services that are responsive to the needs of older people in Hong Kong. The project has engaged different stakeholders, including academic organizations and NGOs, and the project is conducted in phases. Phase 1 began in 2016 and ended in 2020, and Phase 2 began in 2020, which is currently still ongoing. To promote integrated care, the project adopts a community-based care approach consisting of 3 focus areas. The first area can be unpacked into 2 strategies that are essential for achieving integrated care. First, to identify older people in need of care in the community, we form partnerships with community elderly centers to undertake needs assessment for older people. Second, to promote healthy aging and mobilize community resources to meet the needs of older people. The project supports elderly centers to develop and organize health promotion programs that target functional ability. This approach is aligned with the WHO ICOPE approach, which also involves step care pathways such as screening, assessment, and interventions to address the health and social care needs of older people. The second area is capacity building. We developed a capacity building program for social care providers to strengthen their knowledge and skills to perform these assessments and deliver health promotion programs that target functional ability. The third area is an evaluation of the readiness of social care providers to implement the ICOPE approach, which is crucial to facilitate a paradigm shift towards person-centered and integrated care, using an integrated medico-social model as a basis. In collaboration with 100 community elderly centers, we conduct a territory-wide longitudinal survey to monitor the health and social needs of older people. Older people aged 60 years and older were assessed annually, and we designed a needs assessment form covering a list of common conditions, geriatric syndromes, and functional assessments. As of April 2022, we have collected data from over 17,000 older people where their mean age was 74 years. The majority was women. Over 40% had secondary and higher education, half were married, and 1/3 were living alone. Our data shows extensive levels of unmet needs regarding chronic disease. Over 60% had hypertension and 50% had high cholesterol. And we can also see that the percentage of people with memory complaints were high, up to 79%, followed by frailty, up to 62%. Using the survey data, we calculate an intrinsic capacity score, which covers 6 conditions associated with intrinsic capacity decline. These conditions were memory complaints, limited mobility, malnutrition, visual impairment, hearing loss, and low subjective well-being. The IC scores ranged from 0 to 6, with high score indicating lower intrinsic capacity. We found that over 85% of participants had a score of 1 or higher, indicating IC impairments are highly prevalent. By conditions, the most frequent conditions associated with IC decline was memory complaints, followed by limited mobility. Our findings highlight the need for increasing community capacity in providing assessment and interventions, and this will enable integrated care for older people to be implemented and possibly alleviate the burden on the health and social care systems. We also found a great relationship between IC score and risk of adverse outcomes. Participants with IC score of 3 or above were associated with high risk of developing incident polypharmacy, incident incontinence, and incident functional limitation at the 3-year follow-up. The findings reaffirmed that the accumulation of impairments in IC domains can lead to a progressive functional decline. So the identification of older people with IC impairments might help to formulate early interventions and promote healthy aging. To promote healthy aging and mobilize community resources to meet the needs of older people, the project also supports the elderly centers to develop and provide health promotional programs that target functional ability. The programs focus on 5 areas, including exercise, healthy aging, cognitive training, social connectedness, and mental health. Routine data on program participation were collected using a custom digital event management system. So far, over 13,000 health promotion programs were organized with over 153,000 attendants. So which type of programs are more effective? We use routine data to explore which programs are effective in improving subjective memory and frailty status, as these 2 conditions are the most commonest geriatric symptoms of our participants. On the left, you can see that a higher proportion of participants who had taken part in video game training had improved their subjective memory than those who did not take part in the training. And on the right, you can see that a higher proportion of participants who had participated in aerobic, resistance, balance, or stretching exercise had improved their frailty status than those who did not participate in those exercises. Therefore, center-based cognitive training with video games and aerobic, resistance, balance, and stretching exercise offer great opportunities to prevent cognitive decline and frailty and thereby care dependency. The project also piloted a care model, integrated screening, in-depth assessment, personalized care plan, and coordinated service for frailty prevention. You can see that a higher proportion of participants in the intervention group had reverted from frailty or frailty status to robust status than the control group participants. The findings show that an integrated health and social care model can improve frailty status among older people. To strengthen the capacity of social care providers to conduct these assessment and deliver health promotion programs, we also developed a capacity building programs covering 4 modules. Interim evaluation results revealed that the modules were well received. 80% of participants mastered the skill to perform the assessment and discuss the results with older people, and over 70% of the participants were confident in performing fitness assessment, providing nutrition information about healthy diet, and providing information about self-management of medication and incontinence, as well as for prevention. We also evaluate the readiness of social care providers to implement the ICOPE approach. Engagement of social care providers is of particular relevance to achieving integrated care for older people, given that from a service perspective, they are a significant subset of elderly care providers, providing first contact for addressing older people's basic care needs. We conduct several focus groups, and qualitative information regarding barriers and facilitators to ICOPE implementation were collected. On the right, you can see the composition of the participants. They worked across a range of roles in community elderly centers, including service directors, center in charge or managers, social workers, and project officers. So let's look at the identified barriers and facilitators. They are often 2 sides of the same coin. For barriers, human resources and financial constraints, limited knowledge of older people's care, and limited competencies for designing health promotion programs among social care providers were highlighted as barriers. A lack of referral system to healthcare was also highlighted as a barrier. This was a shared challenge despite social care providers can recognize the health needs of older people. Also, limited physical space was cited as a barrier with respect to delivering health promotion activities. And the increased workload associated with the adaptation to the use of ICT during the pandemic was also cited as a barrier, as older people generally have lower eHealth literacy. As well as highlighting the barriers, we identified several facilitators. First, community needs assessment was cited as an enabler. The of older people. Second, staff training as well as mechanisms that enable them to gain in-house skills would enable the provision of health promotion programs. Third, a coordinated referral network for older people with needs, as well as good access to shared resources across partner organizations were also cited as facilitators. And finally, policies or organization strategies and financing mechanisms to support health promotion were also highlighted as enablers. So far, the eHealth project has generated some tools, infrastructure, experience, and evidence to support ICOPE implementation. So a brief project milestone here. The project has developed a needs assessment form for social care providers to identify older people in need of care in the community. The project has also engaged community elderly centers to meet needs of older people, supported by a variety of health promotion programs. Also, the project has developed a community building program to empower social care providers to conduct needs assessment and deliver health promotion programs that target functional ability. We have also evaluated the readiness of social care providers to implement the ICOPE approach, learn what is working and what may need to be updated. Based on the project findings and experience gained, a continuum of strategies could be established to foster integrated medical and social care. One possible strategy would be to develop automation tools with adaptation to the ICOPE WHO ICOPE app and link care process to enable more coordinated and continuous service for older people. Another possible strategies would be to empower health and social care providers to adopt and implement ICOPE models in elderly care in Hong Kong. As well as this, it is important to enable timely referral and service provisions for older people with health decline. I think this action requires new partnerships with local communities, for example, DHCs and other voluntary sector organizations, etc. Successful implementation of ICOPE approach requires coordination between multiple parts of the medical and social care systems. And here we just propose some of the possible strategies. There are many other viable ways for facilitating ICOPE implementation, and we could use the WHO ICOPE handbook and the implementation framework as guidance. And by adopting the ICOPE approach, we hope that the future will see far more care delivered in the community to support people with complex problems cutting across multiple sectors and providers. Acknowledgements. We extend sincere thanks to our project funder, the Hong Kong Jockey Club Charity Trust. Thank you to our project partners, Jockey Club Institute of Aging, Jockey Club School of Public Health and Primary Care, Big Data Decision Analytics Research Center, and Senior Citizen Home Safety Association. Also, thank you to the 23 NGOs and all social care professionals. And last but not the least, thank you to all our project participants. Thank you very much.
Thank you, Dr. Yu. He's come to the 5 minutes Q&A sections. Ladies and gentlemen, you're welcome to raise your questions. Please type your question in the chat box and Dr. Yu will try to answer it accordingly. So the first question is, thanks for sharing the project findings. The project has mobilized Community Elderly Center to offer a range of health promotion programs. Did you encounter any difficulty in engaging older people to participate in health promotion programs? What are your suggestions to motivate older people to participate in health promotion activities? Dr. Yu, please.
Okay, thanks for your question. Yes, over the past 2 years, our project partners have provided a range of health promotion programs, but we found that participation levels among older people with declining capacity was actually not high. We interviewed some older people and some social care providers, and I think there are some older people, particularly those who are frail, are reluctant to participate. They have low self-efficacy, which makes them less likely to participate, and also many older people are not aware of the importance of maintaining intrinsic capacity. So in order to motivate older people to participate in health promotion programs, the programs should be based around the needs of older people. We propose to develop an app incorporating community needs assessment and personalized individualized recommendations, and maybe some home-based interventions with adaptation of the WHO ICOPE app, which allows continuous monitoring of changes in intrinsic capacity and helps improve self-management behavior among older people. And also, it is important that the programs are also tailored to older people's preference and capacities. And I think opportunities to be provided to them to share their views and wishes. It's possible that we can co-design some programs with them. It can be an empowering process.
Okay, thank you, Dr. Yu. So another question is, thank you very much for the presentations and the proposed actions to facilitate the integrated care. And I would like to ask, how will you, on the project, put the plans in actions? Do you have any advice?
Thanks for your question. I think the starting point of facilitating integrated care can be an adoption of community needs assessment or the WHO ICOPE screening tool in community elderly centers, so that priority conditions associated with declines in intrinsic capacity of older people could be identified in the community as the first step. And the second step is to mobilize and support existing healthcare organizations to undertake person-centered assessment and care planning for those who were identified with limitation in intrinsic capacity. And to do so, an integrated medical and social care network and referral pathways to be established so that social care professionals can refer older people to a range of health services, and that health professionals can also refer them to a range of social activities. It's possible that we could identify the community resources that could be used to support older people to maintain intrinsic capacity, and then set up a district-based network to connect elderly centers with healthcare providers, for example, DHCs and some private health clinics, and pilot some referral pathways for management of some common conditions, for example, cognitive decline and frailty. And also, as a researcher, I think it is important to demonstrate how the ICOPE approach can enhance the effectiveness and quality of care for older people from the local context, which will inform policymakers to recognize the importance of ICOPE. I think strong leadership is needed to make integrated care a priority. Thanks.
Okay, thank you very much for Dr. Yu, and also thank you for the Q&A sections. So thank you very much for your participation. Thank you. We will then move to the NGO Forum sections. We are delighted to have representatives from NGOs to share their experience regarding digital health in integrated care of older people. May we first invite our moderator, Professor Jin Wu, Director of CUHK Jockey Cup Institute of Aging. We would like also to invite our guest speakers, Mr. Kenneth Chow, Service Director, the Hong Kong Young Women's Christian Actions Associations, Mr. Wilson Chu, Senior Social Work Supervisor, Caritas Service for the Elderly, Mr. Francis Lee, Elderly Service Director, the Neighborhood Advice Actions Council, Ms. Olive Sin, Deputy Social Service Coordinator, Elderly Service, Port Oid Hospital. Ladies and gentlemen, if you want to listen to Cantonese, please click the Planet button on the bottom right corner. Otherwise, you will listen English spontaneous interpretations. 好，咁我哋而家
The most important thing is that we now have the opportunity to look at how they view this project and how the project is able to help the sector. Actually, there are two issues on the events and activities that the elders can participate and what will be the way forward. So can this model be continued? Let me first ask Mr. Chow to start. Right. First of all, thank you CUHK and Jockey Club. Thank you very much for inviting us to share about the scheme and also our cooperation experience. In fact, in the past, in relation to promotion of eHealth, actually, it can really help older people in managing their own health condition by means of an electronic and online system. Actually, they attach much importance to the health. I guess you all understand how elderly people are like, but then they need to face some difficulties and challenges. In the future, in the long run, if we are to promote eHealth, many elderly people at the age of 65 or above, well, 30% of them do not have this relevant experience. So this is really a big challenge. So how they can make use of the smartphone in the area of eHealth in terms of data and hardware. So I think this is a very important topic that we need to explore and think about. Of course, another thing is elders who can take part in the process are actively engaged in the eHealth self-management work because they find it very convenient. So they are able to monitor their own data online, and they can see on a continuous basis the situation in the past half a year or even 1 year. They can see their own data. So this is very important for their self-management. Under the pandemic, if there are videos teaching them to use RAP, that is the rapid test kit, then I think elders welcome this arrangement. So on these dimensions, how can the information be passed on to them effectively? I think that the online tool is very helpful to the elders. So in terms of their exercising and also information on primary health care, I think the eHealth platform can enable elders to receive information very quickly. And they can also make good use of the information. There is some other work experience. We encourage elders to monitor their own blood sugar level and blood pressure. So they should input the data onto the platform so that they can monitor themselves more easily. And on the back end, we have medical colleagues, we have nurses who can monitor the situation. They can remind the elders about their health. So with this assistance and with this circulation, elders will find it easier to understand their own health condition. So I think I will pause here. I'm sure other colleagues from other organizations will share more. Right, thank you. Now let's invite Mr. Wilson Chui to share with us. Thank you, Professor Wu. Thank you, organizer, for inviting me. Well, we have already implemented the eHealth scheme for 5 years. And in fact, there are 4,000 elders who have benefited from the scheme. And as Mr. Chow just said, concerning the electronic system, I think the challenge to the elders is big. At the beginning, we had to put in a lot of effort to support and teach elders to use the system. But then elders are very receptive. After some time, they are able to grasp the skill, and their use is very smooth. So if there is the opportunity, I think we can work more with developers so that they can produce more elderly-friendly products, so that elders can use the products more smoothly. I think in this way, it is very helpful to promotion of digital health. Besides, in this scheme, I think the elders are also very anxious. Looking at preliminary data, well, at the beginning, it seems that they were forced to participate in the scheme, but later on, they have formed a habit. And we have passed on to them a concept, and that is they should manage their own health. I think this point is very important. We need to enable and empower them so that they can also play a role and they can also pay attention to their health needs. I think in the implementation of eHealth, this is a very important concept, and it is worth further promotion. Number 3, thanks to CUHK team for offering a lot of useful data, especially survey from the survey and from the nurse stations and ER station and so on. So the data help us very accurately understand elderly's needs. In terms of health, the elders may have a lot of difficulties and worries, and we can think of services that we can provide. For example, we can offer more care to them, and we can organize more events and activities so that the elders can get engaged in some appropriate exercises. In the past 1 month, well, there were a number of organizations participating, and on average, 500-odd elders took part actively in the activities. And every month, there are around 3,000 man times of blood pressure checking. So we can see that elders have formed a habit of self-management. Thanks to the healthcare teams, during the test and inspection, well, of course, there are elders who are chronically ill, and they will have worry. And so during or under the scheme, there is support from nurses. And our colleagues in our organization care a lot about them. They offer support to them and assistance. And when necessary, they refer medical teams to deliver service to the elders. So these are things that we have seen. Besides, well, in the elderly centers, of course, there are some elders going to elderly centers. At the same time, there are many elders who cannot go to elderly center for different reasons, so they can't use this service. So I hope that an electronic management system or service can be added. This should be the future direction. There are elders who live in remote areas. It's difficult for them to go to elderly center. So in the future, if there can be development of more service which are available easily, then I think the barrier of service can be removed. Thank you. Thank you. Now, let's invite Mr. Francis Lee to share with us. Thank you, Professor Wu. Thank you, CUHK, for the invitation. And we need to thank the Jockey Club for their support to the eHealth scheme. Well, are we able to help the elders? Of course. The answer is positive. In elderly service, I think the theme is health, and this is all along the main direction. Well, elders are aging, of course. This is a big need. And for this scheme, the electronic platform is used, and there are also many events and activities organized together by elderly centers. So a big network is built, and a habit can also be formed. There are 2 points about the habit. First, people are more and more conscious of health. As Wilson just said, we can help the elders to be more aware and more conscious of self-management. So we emphasize the self-management by the elderly of their own health. I think this concept needs to be deepened. It has been talked about for many years, but how can we deepen the concept? I think this is important, and we should move towards the ICOPE direction. The second point is that we need to make use of technology to form the habit. So IT and also digital electronic technology can be used to tie in with health management of the elders. When it comes to elderly's use of technology at our center, well, I think when it comes to elderly, there are at least 2 generations. Some are even more senior, but some are the young old. For the young old, I think we can be more proactive. We can be more forward-looking and develop more different apps and management methods for them. In our elderly center, And among our senior population, there are many who are rather old, those who are in their 70s and 80s, and they are important targets of our elderly center. As Kenneth and Wilson said, there is a digital barrier for these elders. And some elders are not used to using digital phone or smartphone at all. So while we need to form a habit of self-management of health, we need to help them break through the technological difficulty. I think this is important to the overall development. The third important direction is cooperation between healthcare and social welfare. I think this is a good cooperation this time because there are nurses monitoring the elder situation, and in our center, there are many events and activities centered around health. So the two things have to work together. When it comes to long-term development and when it comes to human resources and cooperation between healthcare and social welfare, well, things should no longer be only project-based. Should there be some core service, I think we need to think about that. More and more people invite us to organize health-related events and activities, no matter whether the activities are about awareness, cognitive ability, or health. Well, there is home care, but then there is not the necessary establishment in elderly center to do that. So I think the neighborhood support or neighborhood coordination will become difficult. Under this scheme, many elders come to check their blood pressure. I agree with Wilson. It is important to build long-term habits, especially about self-management. And these self-management devices should be able to penetrate people's homes. So people can check their own blood pressure, and through Blu-ray, the data can be sent to a cloud database. I think we need that development in the long run. And I think this management system can give further help to the elderly. So this is my experience sharing. Thank you. Thank you very much, Mr. Lee. And finally, let's have Ms. Olive Sin. Thank you, Professor. Regarding eHealth and its operation in the center, I would like to show you this picture. I don't know whether you can see it. Yes. Regarding the eHealth project, it is like some resources have fallen down to the center, and there is then a ripple effect. Well, I would like to make 4 points. First, regarding eHealth, well, as Francis just said, the elderly population consists of a number of generations, and sooner or later, I will be a target of elderly center. And right now, for the educational attainment and need for autonomy and need for privacy among elders, well, all these are rather significant. And eHealth can meet these needs. In the past, when elders came, they needed help from our colleagues to check their blood pressure, but now they already have records in the center. And as the speaker said, more autonomy can be developed. Well, we want elders to take greater part in elderly service. And in the past, when I was studying in school, elderly centers were like social resources. They mainly offered recreation service. And when the elders have health problems, when they suffer from a stroke and they need to be institutionalized, then how we can help? Right now, there is a shift. More importance is attached to elderly's health and their own health management. So there is more work done in the area of prevention. In fact, there are controversies among colleagues. In the past, in elderly centers, there was no nurse. And would it be okay for us to take up health-related tasks? Or should we concentrate on community service? Now, with the elements of eHealth, our colleagues and the elders will concentrate more on the importance of health. We have seen some successful examples. Well, for some elderly, their blood pressure is consistently high, and we immediately offer interim measures, so they will not need to wait till they get a stroke and come back to us to seek help. And then number 3, through CUHK, a lot of data are available, for example, WBS data. Now, when we formulate service development plan, some insights have been given to us from those data. Well, elderly's health is a broad topic. So which areas should we concentrate on? Teeth, nutrition, or what? Well, with the data, our colleagues are given insights on how to develop the service. And finally, I would like to say that overall speaking, when the elders are aware of self-management of their health, and for example, they will take note of their blood pressure readings on slips of paper, but then nobody will pay attention. Now, there are people who regularly check those readings. And then apart from service development in the center, I realized that our colleagues are more aware of health. We also grow old. So regarding health management, it should start from young age. So the eHealth element has helped our colleagues to be more aware at the same time. And the third point is on the institution level. Well, other colleagues or other grade workers, other departments will see that elderly centers mainly provide recreation service. But now we always talk about eHealth. So what are the differences from the blood pressure check by elderly centers in the past? Well, I think we will think more about that on institutional level. For the district health centers, I think this concept is going to be incorporated. So there is a change here. Not only the elders, I think there is a rippling effect which will spread the influence. There are some elders who do come to elderly center. And some elders stay at home. How can the electronic system help them so that they can stay at home while they can also come to the center? Well, there is a query whether elders will just stay at home to check their blood pressure and they don't need to come. Well, they may do health monitoring at home, but then there can still connection with the center. This is important because elders do need social life, and the centers can play this role. So that's all from me today. Thank you. Thank you, everyone. We have still some time left. Let's see whether there are questions from participants or from audiences. Does any audience want to join this discussion? It seems that COVID-19 is something good to us, especially when we develop eHealth. Without COVID-19, we won't be doing that so fast. We have not thought of organizing anything on Zoom. Of course, there are people who don't understand, but I think it's still feasible for many people. I think that eHealth has prepared the elders to be more receptive of electronic technology, especially under COVID-19. Right, very good, thank you.
Mr. Chui, Mr. Lee, and Ms. Sin for the sharing. The sharing is very fruitful. Once again, thank you very much. We will now begin the sections by inviting Professor Angela Leung, Deputy Director, WHO Cooperating Center for Community Health Service, School of Nursing, the Hong Kong Polytechnic University, to introduce her topic, ICOPE Training in Hong Kong. Professor Leung, please.
Thank you very much for the organizers to invite me to join this symposium. In particular, thank you for Professor Wu to invite me. And it is my great honor to share with you some of the experience that we have in providing the training to the people here in Hong Kong to conduct ICOPE assessment. So I think before we start, probably we would like to revisit what do we mean by ICOPE. And ICOPE probably is a very important elements in the community because it's a community-based approach, so as to let us to assess a person, in particular the older people, their functional ability. And we really want to see that this is a person-centered care approach that includes the health professionals as well as the social care providers. And in this framework, in this ICOPE framework, basically many people can help out to screen the people who are at the risk of care dependence in the community. And at the same time, we would like to develop and perform person-centered assessment in the primary care settings. After knowing the situations of the older people, we would like to design a personalized care plan for the clients. So with these important components and understanding about the ICOPE, we move on to talk about what are the main contents or what we call the domains in the ICOPE. The very key concept is about healthy aging. Right? So healthy aging is all about developing and maintaining the functional ability of the persons so that the persons can foster their well-being. This concept is very important because in the past, actually, many of us actually focus on the illness of the older people. But with the concept of healthy aging, we know that everybody can maintain their functional ability along their lifespan. And the most important is that each one of us actually have the intrinsic capacity. The intrinsic capacity actually covers a lot of capacities of the person. As you can see on the right-hand side, that it includes 6 domains, namely the locomotor capacity, psychological capacity, cognitive capacity, hearing, visual, and vitality. I think we often miss out the visual capacity and the hearing capacity in many of the assessment that was conducted by nurses. Knowing about the intrinsic capacity, we would definitely need to know that as we age, our intrinsic capacity would decline, as you can see in this diagram, that the more advanced age a person is, the intrinsic capacity would be lower. But having said that, there's still some function that we can perform. So our functional ability, hopefully, we can maintain it as much as possible. So with this concept in mind, we think that it's very important to understand the situations of the older people. That's why we conduct a training to our nursing students to conduct the comprehensive assessment in the community. This is very important because nursing students were trained up to perform our nursing care in acute hospitals. But in the community, they have limited information about that. So that's why this training actually filled the gap of the training. So the objective of this ICOPE training is to develop their competence to perform screening and comprehensive assessment for the community dwelling older people. And at the same time, we would like to see that the nursing students are able to develop personalized care plan for older people. And if necessary, they can refer our clients to the professionals for follow-up. So this training is a 2-day training that we developed according to the WHO guidelines. The first day is a theoretical input. And the second day, we would like to really see that they can practice their skills in the laboratory. We have a nursing laboratory for them to practice. And at the same time, in the afternoon, we would conduct an assessment on their skills competence. So after this 2-day training, the nursing students are able to perform all the assessment in screening and comprehensive assessment under ICOPE model. Before they go for the on-site, they have the training in the school. But by then, they would be arranged to go to the community district centers for conducting the comprehensive assessment. So on site, actually, we have communicated with the social workers so that the social worker in charge in the district community center can conduct a briefing session for them before they meet the clients. And after meeting the clients, we also have a debriefing section. So as you can see, we actually follow the ICOPE handbook, which is published by the WHO. And then the first step is that we would conduct an initial screening for everybody. So the initial screening can be done within 10 to 15 minutes because there are only 9 questions over here, but it covers 6 domains of the intrinsic capacity. So whichever one of the items that the nursing student found the older adult have some issues over here, then they will check the box. Once the box is checked, then that client indicates that there is at least one intrinsic capacity decline here in the screening. So then they would go for the comprehensive assessment. So for the comprehensive assessment, as we mentioned, we have 6 domains here, and each domains we actually use validated instruments to measure that particular domain. For example, for the cognitive part, we use Mocha, and for the vitality, we use MNN. As for psychological capacity, we use the PHQ-9, etc. For the hearing and the visual capacity, we have different tests like the whisper test and the Weber and Rainey test, etc. For the visual acuity, we bring along those big E so that it can be sort of tested on site. For locomotor capacity, we use SPPB, which is a very standard measurement for assessing the physical mobility of the older clients. And we also bring along some dynamometers so that they can check out the hand grip strength as well. We are also interested to know about whether these older clients have enough social support and care. So that's why there is a self-reported capacity instruments that for them to use. With all these assessments, then the nursing students have some understanding of the client's situations. So that's why it's the time for them to prepare a care plan for the clients. So this care plan is really individualized. As you can see that we actually put down some of those issues that the nursing students identify, and then show this platform care plan to the clients and let them bring them home. So with this, we actually talk to the clients and see whether they would like to do something so as to revert some of the decline in intrinsic capacity. And at the same time, we also encourage the older people to talk to their family members and friends so as to get some help from them. So this care plan, I would say this is a very initial care plan that we have just tested out, and see that this care plan basically is accepted by quite acceptable by the older people and their family members. So WHO basically have developed some mobile device for everybody to work on this ICOPE assessment. Like this one, this is the ICOPE app that can be downloaded from the App Store and Android store as well. But in Hong Kong, we don't actually use this one. The reason is that, first of all, we want to see the extension, that see whether this kind of electronic device can be used by local people other than nursing students as well. So in this training for the nursing students, we just introduce this app to the nursing students, but we actually do not use it. But we prepare a lot of things for the nursing students. We prepare a portable assessment pack for them, and we put all the instruments that are needed for doing the assessment in the community so that they can quickly grasp the pack before they go. And of course, we still use the questionnaire, which is pen and paper format, so that they can quickly carry out the assessment and drop down all the records. And to remind them, we put up a protocol for them and let them flip over the protocol if they forget about all those procedures when they are doing the assessment. And we also give them some consent forms and information sheets. And so before doing the assessment, actually the nursing students would ask the family members or the other people actually give consents and understand that what they are doing here in the assessment. By the time when we did the assessment in the community, it's still a COVID time. So that's why all the students have to conduct COVID test before they go, and they have to get a negative result. And on site, the workers would check out the results and conduct a briefing sections for all the nursing students. The students actually pair up in a way that 2 to 3 nursing students go to one center for one section, and each section, basically they can conduct an assessment for about 3 to 4 older people. So by the time when the older people come, the nursing students will explain this assessment for them and get the informed consent by writing. And before they conduct the screening, they actually explain the procedures to the older clients. And they would conduct the screening, as I mentioned, and work out the care plan with the older people. And some of them actually, they are accompanied by the caregivers. Before doing any kind of assessment, we keep on reminding the students to go earlier, at least half an hour earlier, so that they can do some on-site preparation. So I just showed to you that they have to set up with chairs and mark the place that where they can carry out the walking distance assessment and the visual acuity assessment as well. So after the assessment, that is very important that students work with the older clients or with their caregivers to work out some actions in the next few months. In some occasions, older clients may have significant intrinsic decline, so they have to be referred to professional people. So the center staff would have to follow up. And after the clients left, the center staff would also conduct a debriefing section for our nursing students. And on average, basically, for conducting the screening as well as the comprehensive assessment, it takes about 60 to 70 minutes to complete everything, as well as carry out the care plan. So when we look back, the training that we did for 33 nursing students, we can see some of the challenges over here that first of all, I think the concept of intrinsic capacity is a bit different from the traditional illness model. Many nursing students actually are quite familiar with the illness model. So by the time when we introduce the intrinsic capacity, it takes some time for us to accept this concept. At the same time, we have to distinguish the two instruments, the screening tool as well as the comprehensive assessment, so that students would get to know that when they should carry out the comprehensive assessment. In many countries, I know that when they conduct the ICOPE assessment, they just conduct the screening tool only without carry out the comprehensive assessment in step 2. And so it is quite challenging in some way that for the comprehensive assessment, which is one assessment only that covers a lot of domains, that nursing students should learn about that. And different domains have different requirements for doing the assessment. So they have to do a lot of practice before they go to the community. At the same time, we have arranged clients to come on time. So basically, it's in some way, the nursing students may find that it's the time is somehow pressurizing. They have to finish everything within 70 minutes so that the next clients will not wait for them for too long. So we keep on reminding the nursing students that actually this is a very good example for us to learn how to conduct assessment and providing care to the older people in the community. So we have some warm reminders notes. I want to share this with you that in our training, we keep on reminding our nursing students what kind of dress code that they should have, and they have to be punctual in the community, and they have to follow all the regulations related to COVID as well. So for their psychological comfort, we put up our telephone number and email for them, so that they, if they have any questions, they should feel free to contact the project team. And we keep on reminding them that assessment is only one skills, but the most important is that how we can communicate with the other clients in the community, and how much they understand about the assessment score is also another challenge for them. So this is a chance for them to increase their capacity to do the comprehensive assessment, as well as communicating with the older people. So this is a holistic approach in nursing care. So having sharing all this experience with you, I think it's time for us to actually think about that. What is the best thing that we can do for ICOPE in Hong Kong? And actually, PolyU, the WHO Collaborating Center, the center that I'm in charge of, actually have been working very closely with the WHO headquarters, in particular the Aging and Health Unit. So actually the curriculum that we develop here for nursing students, we share this with the WHO and with other countries as well. And we keep on providing different types of consultancy services to different countries. We work with the Ministry of Health and NGOs in different countries. For example, in Cambodia, we have been helping them to set up all this kind of training as well. And to a certain extent, I am sure that training curriculum cannot be carried out well if it is not tailor-made. So that's why we have discussions with the stakeholders in different countries in Western Pacific, and see what are the most important components that they would like to look for. For example, in Cambodia, they like to look at the oral health as well. So by the time when we develop the ICOPE training curriculum, we actually add in the oral health issues with them, so that they that would fit into their national plan in health. We also work with WHO to review some of the findings. WHO has been initiating different kind of pilot program in France, in China, in Brazil, I think. So they actually work out a very nice report to show the findings of all these pilot programs. So as the WHO Collaborating Center, here we help out to review this report. And we also share our local data with the international audience. As you can see that we publish the work that we have done in Hong Kong. And we also, based on these findings, I would say that training our nursing students is one of the important things that we should do and carry out. And the other side of the cons is that we can see that older people actually need our help in all this kind of assessment, because from our study, we see that the community dwelling older people in Hong Kong, many of them actually suffer from intrinsic capacity decline. And in this slide, you can see that 70% of them actually suffer from that. So no one would know about that before we actually conduct the assessment. So doing an assessment in the community is very important. Just want to share with you some of the findings that we have published, that you can see that 64% of the older people have more than one decline. And the most severe part would be the locomotor capacity, followed by the hearing capacity, and then followed by the cognition part. So you can see that with this comprehensive assessment conducted by nursing students, that we will be able to identify the groups that are at risk, or they actually suffer from intrinsic capacity decline. So with this understanding, we should be able to provide some tailor-made interventions for them. So as a conclusion, I would say intensive training, only 2 days only, is good enough for training up our nursing students to conduct this ICOPE assessment in the community. I can proudly say that the nursing student has been doing well, but of course their work would not be a successful one if the on-site workers are not supporting us. So I have to really acknowledge their cooperation and support in the logistics in doing all this kind of assessment. And we have to say intrinsic capacity decline is pretty common in Hong Kong. And I hope that in future, it's not only the nursing students are trained for conducting ICOPE assessment, but many of the health ambassadors, they are non-professionals. They could also help out to conduct this kind of ICOPE training. And our center is very happy to help out to conduct this training for the health ambassadors in the community. And thinking about the future, I'm sure that the care plan can be do a little bit more, better if we can work out some co-design care plan with the older people, their family members, as well as the frontline workers in Hong Kong. So that's all I want to share with you. I hope that you will have some comments and questions for me. Thank you.
Thank you, Professor Leung, for your great sharing. So he's come to the 5 minutes Q&A sections. Ladies and gentlemen, you're welcome to raise your questions. Please type your questions in the chat box, and Professor Leung will try to answer it accordingly. So the first question to ask Professor Leung is there an issue with care plan in implementations? For example, getting the senior to see a doctor for future assessment. Professor Leung, please.
Right, thank you. Yeah, this is a very good question. That this is something that we want to follow up. In our last study, actually, we actually identified some people need to see doctors, and even they need to see optometrists, and they have to receive the hearing test as well. So what we do is to conduct this referral, but unfortunately, we have not followed up. We have not actually go to talk to the older people and their caregivers and check out whether they actually follow our advice. And I think this is something that we should carry out in the future. Yeah.
Thank you, Professor Leung. So goes to the second question. Do you think that the training program can be applied to other health and social care professionals?
Yeah, sure. This training program is definitely can be transferred to any professionals, including the health professionals as well as the social care professionals. Like in Cambodia, actually, as I mentioned, that we are doing the consultancy work for them. We are planning to conduct a training to the nurses, the registered nurses and the doctors in the primary care settings. So that's why is possible. But if we train up nurses and doctors, maybe some of the training materials have to be modified. So that's why we say this kind of training program has to be tailor-made in some way. Yeah.
Okay, thank you. Thank you, Professor Leung. Okay, so see the final question is, during the ICOPE comprehensive assessment, how do you manage other issues such as urine incontinence, pain, and other issues?
Yeah, the urine incontinence, pain, and this type of issues actually was not included in the ICOPE comprehensive assessment. So if we are interested in this, we have to add in some more assessment for knowing this area. I would say why ICOPE is sort of excluding these items. WHO actually has done a lot of work. They did a lot of research in different countries and work out this ICOPE model. And they try to select the most important part. I know other people have a lot of issues like the urinary incontinence and pain, these type of issues, but we are not saying that these issues are not important, but the 6 domains that is included in the ICOPE model basically are the very key components that we need to know about it before we move on to investigate some other issues. With the understanding of the mobility, maybe because of the mobility, they cannot go to the toilet immediately, and that leads to some sort of incontinence in this way. That's why some basic stuff like the 6 domains of the intrinsic capacity in the ICOPE model give us some insights about the current situation of the older people. So I would say this is a basic, and we can add on some more assessment to see how we can deal with some other health issues that is suggested by discussion. Yeah.
Okay, Professor. Thank you, Professor Leung. I totally agree that this is a very important issues that we have to face on. And I think there we have still another questions. We are now just waiting our participants to type the questions. So please wait for a while. Thank you. So the last question. Let's see. Once again, thank you very much for Professor Leung. You contribute today's time. We're very fruitful and so delighted that you can just join our symposium today.
Yeah, it's my honor.
Okay, thank you very much. Actually, just because sorry that time is running out, so we have to move to the next sections. Once again, thank you, Professor Leung, for your contribution. Thank you very much. Hope to see you soon. Thank you. Bye-bye.
Yeah, we'll see you in the afternoon. Thank you.
Here comes to the panel discussions on the topic of the future directions of medico-social integration in community care of older people in Hong Kong. May we first invite our moderator, Professor Jin Wu, Director of CUHK CUHK Institute of Aging. We would also like to invite our guest speakers, Dr. Cissy Choi, Head of Primary Healthcare Office, Food and Health Bureau, HKSAR Government, Dr. Carolyn Kng, Consultant, MNG, Head of Divisions, Geriatric, HKEC Service Director, Primary and Community Healthcare, Chairman, HK Geriatric Subcommittee, Hospital Authority, Dr. Ruby Lee, JP, Consultant Family Medical, Elderly Health Service, Department of Health, HKSAR Government, and Dr. Pamela Tin, Head of Healthcare and Social Development, our Hong Kong Foundations. So I'll pass the mic to Professor Wu. Thank you.
Hello, good morning. Thank you all for participating in this panel discussion. You're all very important people because you all represent different facets of our Hong Kong services to older people. So you each have a slightly different perspective. And I would welcome your input into what we've been talking about. Firstly, may I invite Dr. Cissy Choi, Head of the Primary Care Office. We have a new, fairly new initiative in the establishment of the district health centers. So this is a new thing. So would Dr. Choi give us some insights about your services and how it fits in with what we've been talking about? So this is technically not very satisfactory. So shall I invite Dr. Carolyn Kng first? I can see you.
Hi. Good morning to everyone, and thank you very much for inviting me, Professor Wu. I'm glad I see many friends here. So when we talk about the future direction of medico-social integration, I think the Hospital Authority has last year drafted some directions for medico-social integration in Hong Kong. Okay, so the 3 areas that we all agree are going to be paramount will be firstly primary care, empowerment. Okay, so working basically with the district health centers. So patient empowerment, that's number 1. Number 2, rehabilitation, right? Because we have quite a few apps that we can facilitate this in HA. And thirdly, end of life care. Okay, so I think those are very intuitively interfaces that HA or medical people will have with the community partners. Recently, because of COVID, I think infection, okay, COVID pandemics has also shown us that digital health is very important in such medical social integration. So for what sort of perhaps applications or means or channels that we can actually facilitate such digital health will be listed here. And I got this list from the New England Journal of Medicine, the Catalyst. And I think I can show some examples. Okay, so basically at the center of medical social collaboration, I think there are two very important facets, right? The first facet is sharing information. Okay, so how do we share information? We share information obviously through the electronic health record sharing system. And now we have a patient-based portal, which is the HA Go. I think I'm sure many of you know more about this. Initially, we had difficulty getting people to register, but because now you can use it to book appointments, you can use it to pay when you go to clinics. This has become much more widely used. I heard it's probably, I don't know how many, but definitely the numbers have gone up. And through this very important portal, we can push patient information, and we can certainly even push targeted people, right, with targeted information. So another way to share information for medical social collaboration is like, for example, in my cluster, we have a shared website. Okay, so we put not just medical disease specific empowerment information here, but we also put all the community resources. Namely, for example, which NGO does dementia care, which NGO does whatever program, right? And we update it with links to the NGO's website. So we spend quite a lot of time to update this, and the number of hits that we receive is encouraging. Okay, so let me show you how patient information is very vital when we're going to talk about collaboration with primary care. So recently in this year, in April, in fact, just recent, we have 2 district health center expresses in my cluster, all right? And they do patient empowerment. Remember, I said that the basis of medical social collaboration would be empowerment, rehabilitation, all right? And end of life care, and maybe carer support. So for a doctor like me, if I want to refer to an NGO in a clinic, I can't find the referral forms. Okay, where are the referral forms? I mean, there's 1,000,001 referral forms in the clinic. So the key is to have it integrated in the HA system that all doctors have to use, because all the medical records are electronic, right? So here on the first page, you can see there's, all right? And I can put all the information that even gets all the recent lab results. I can write down the medical information history, all right? And if the provider has an EHRS, then they can also access the medication. So this is very important, right? So not only do we have a printout, but this referral is uploaded to the electronic health record system. Okay, so that's number 1. Virtual care is when we're talking about providing teleconsultations. Okay, so for example, the HA Go, which I mentioned just now to you, now has a system where you can sit at home, okay, of course, selected patients, right? You pay through electronic means, you get a notification, you get asked to log in, and you can do a teleconsultation, be it with a doctor or a nurse or allied health provider in HA. Okay, so if you look at the WHO recommendations on digital interventions for health systems, so it's not just the content, right? So you need to have the content. For example, here we have a lot of videos in the HA tele-rehab system, teaching patients how to move their arms, how to mobilize. But these videos, okay, have to be obviously validated by the care professional. And then we have a system called tele-rehab, and the application, which is HA Go, and obviously you need all the Wi-Fi and all the cloud as well to handle that, right, the technical stuff. So, for example, to me, I think the best example to all of us of what is medico-social integration for digital health is your right? Because everyone has it in your phone. You need to have it because if you don't have it, then you can't have a social life. So what is better than medico-social integration example? And you have your vaccine records there. So this is a classic example. How about the old people in OH homes during COVID? What do we have to do? Okay, so for example, here, we can't do this sort of stuff, right? Because this is old people don't have, telephones, smartphones, and certainly in the OH home, they don't have that. So we resort to a more primitive means. So for example, this doctor, and I can tell you that in my cluster, we saw almost 2,500 new cases over the February, March and April pandemic. So, the volume is huge, right? So every morning we get to see new cases in 100 OH homes by the nurse telling us which are the new cases in the OH homes. We log in, we get a proper clinic registration number, and then we use some sort of tele device hooked up to the OH home through the staff, and we view all the OH home patients with COVID, all right? So obviously there must be a system, there must be consent, there must be comply with the telemedicine guidelines by the Hong Kong Academy of Medicine, because there's certain things that you need to do, there are rules, right? And we follow that. But if someone can help me in the OH home, I think that, actually not just virtual care, a lot of the OH home people, they have been really imprisoned in the OH home for the last 2 years, they can't go out, they can't visit. So I think this should be expanded, right? Some sort of elder-friendly device, making sure that the internet is really empowered for the OH home. Some of the places have blind corners, right? We can't even get a line. So and it should be elder-friendly, right? So I think virtual care in the face of pandemic is something that we should think about. Okay, and lastly, I'd like to share a little bit more about the future. I think when we talk about elderly, they are a very heterogeneous group, okay? So we need to do some risk stratification. So I think some of you have heard of that HA actually in a medico-social collaboration program that's been running for years called the ICM, Integrated Care Model, or the Integrated Discharge Support Program. How do we select patients from medical HA to download to the NGO? We use a score called HAPI, okay? Basically, it stands for people who are high flyers in HA. They have a high risk of coming back to hospital after being discharged. And it's a statistical model, and this is all computerized. So it comes up to my nurse every morning. We have a list. We know who is in my hospital with high HAPI score, more than 0.2. That means more than 20% chance of being readmitted in the next 28 days. And we go and hunt them out, and we give them this sort of supported discharge, working with our NGO partner. How about the future? This is only for people who have been admitted into hospital, right? Or they have a risk of readmission. I think maybe something that is a little bit more representative of the patient's not only medical profile, but their functional profile and certainly their social profile, something called the frailty index. This is my wish. So I'm not saying that this is going to happen, but certainly if we could have a dashboard like that for every patient with the age and the HAPI score, which I mentioned just now, their frailty level, which corresponds to certain levels of the clinical frailty, and knowing exactly what diseases they have, whether they have a risk of fall. Okay, this might even tie in with the ICOPE domains that previous speakers have talked about. Okay, and why we need to stratify, because some cases are obviously more suitable for primary care, and some cases might be suitable for rehabilitation, and some cases may be suitable for end-of-life care, which are the 3 areas that HA has designated medico-social collaboration to focus on. Okay, so other things are happening. So even in our wards now, we have what we call eVital, so like a blood pressure machine that sends by Bluetooth to the CMS system. We do have this, I have this in my geriatric ward, the TAMI, and you can program certain programs in it to do cognitive training. So there are a lot of developments also in HA for smart hospitals. So in summary, that's my sharing, and I'd like to see if that fits in with your topic of discussion today.
Yeah, thank you very much, Caroline. So this is all very exciting. May I invite Dr. Choi who will be speaking from the perspective of the newly established district health centers and District Health Center Express, because you would have gathered by now that we have many providers and they are doing great work, but each is slightly different, and the same applies to assessment tools. So we hope to, at the end of the day, draw everything together. So may I invite Dr. Choi to share her thoughts on this topic?
Okay, thank you, Professor. Sorry for having technical issues. While I can hear and see you all, but you can't hear me. Okay, thanks for inviting me, and thanks for all the presentations this morning on the digital health as well as the integrated service model for the elderly. I think with aging population, the people are getting more and more complex with long-term conditions and increasingly requiring long-term support from the community of different services and also the professions. So the fragmentation of services and lack of coordination definitely will lead to poor experience of the people receiving the care. And there's increasing recognition that the need of integrated medical and social services for the elderly would bring the best possible outcome for them. So the actually the integrated care, I think in the Western country actually started for over a decade. In UK, there is a plan for putting the integrated care service onto a statutory footing from 2022. And in Hong Kong, as highlighted in the Chief Executive 2017 policy addresses, the government is determined to step up the efforts to promote the individual and community involvement, enhancing the coordination of services among various medical and social sectors, as well as strengthening the district-level primary healthcare services. The first district health center, what we call DHC, was established in the Ching district in the 2019, and the second one in Central Po commenced service in the June 2021. And it is expected that the Chun Mun, Huang Tai Sin district health centers will commence operation in May and June this year, while the other two districts, the Southern, the Leong, and the also the Chun Wan, will be planned to start operation later this year. In addition to the 11 district health center expresses that across the other 11 districts have already commenced operation progressively. Operating through a medical-social collaboration and private-public partnership, the district health center serves as a hub to provide a more systematic and coherent platform to incentivize the community to work together, to coordinate, synergize, and maximize the community health and social services, as well as to build and strengthen the social support to sustain the health initiative at the individual and community level. The DHC composed of the multidisciplinary team, including the nurse, the physiotherapist, occupational therapists, social workers, dietitians, and also pharmacists. Working together with the network medical practitioners in the private sector and other services providers in the district, we aim to provide a comprehensive and coordinated primary healthcare service, focusing on primary, secondary, and tertiary prevention services. Despite the pandemic situation did affect the service implementation in certain extent, however, the collaborative working in a health and social care system has been strengthened as the response has rested on different parts of the system working together to address the public health emergency, enable the continual provision of the essential services, and support the people to remain well in their communities. The DHC and DHC Express staff have also been working closely with the Home Affairs departments and other NGOs to provide the support to the public in need during the pandemic. And also during the fifth wave, the DHC staff also support the hospital authority in managing the hotlines to support those confirmed COVID patients. Following the establishment of the District Health Center, the government will comprehensively review the planning of the overall primary healthcare services with a view to establishing a district-based, family-oriented, community primary healthcare system that improves the health for all and enhances the quality of living of the people, in particularly the elderly. The government is actually formulating a primary healthcare blueprint, which will focus on studying a series of reforms that measures to strengthen the primary healthcare services and relieve the pressures on the public health system, as well as enhancing the improving the health of the overall public. In the blueprint, it will address some of the barriers that has been mentioned by the speakers. For example, the access to the health services, the adoption of technology and use of electronic health record as a platform for the data sharing and also empowerment for self-management of health. For the assessment part, in response to Professor Wu's comment at the start of this session, I think we did have a standardized assessment tool for the clients in the district health center and district health center expresses. But of course, as mentioned earlier by Professor about the ICOPE, I think we are not easy to include every component of the assessment in our initial assessment with the clients. But we adopt a case management approach and also the long-term membership approach. So we are sure that if we can build a good relationship and trust with our clients in the long run, we can address of their individual problem and help them to navigate throughout the health and services within the community to achieve the best outcome for them. So thank you for inviting me, and I look forward to a very fruitful discussion. Thank you.
Thank you, Dr. Lee. So may I next invite Dr. Ruby Lee, who's in charge of the elderly health centers, which has a longer history because it's specifically targeted towards older people, right? There's an age limit, I think. Yeah. So Dr. Lee, please.
Okay, so Professor Wu, honored guest, ladies and gentlemen, thank you very much for the invitation today. And it's a great honor for me to share some of our experience with you. Today, I'm going to talk about a medico-social collaboration program in elderly health center. And thanks to Professor Samuel Wong earlier today to have introduced the primary care system in Hong Kong. So I will save some on that. And also thanks to all the introduction of new services to come now in place, like the DHC. And I'm going to talk about something that we already have in Hong Kong. Our elderly health centers adopt the family medicine approach, and our assessment to have take reference of many local and international guidelines, including the primary care reference framework and also the ICOPE protocols. And we have a multidisciplinary team consisting of doctors, nurses, physiotherapists, occupational therapists, dietitian, and clinical psychologists, and to provide both pharmacological and non-pharmacological management for our patients. Oh, I have to share the screen. Yeah. Okay, so our health assessment consists of health standardized questionnaires that comprises of health practices, health status, activities of daily living, social support, and we have measurements of BMI, blood pressure, balance, muscle strength, and sensory parameters. And our doctors will look for medical consult in the consultation about symptoms, geriatric syndromes, offer cancer screening and laboratory investigations as indicated. And so we are a highly subsidized service, and let me see, I can. Yeah, we are a highly subsidized service and have been attracting many health conscious elderly to join our service and have a waiting list. However, we would also like to offer priority service for the socially deprived. And so we are seeking help from the social worker and NGOs and to find the hard to reach elders for us. And by the end of 2020, there are 44 collaborating organizations. And we have referral for those who are living alone and who lack care from family members and lack means to access community resources. And now compare with our usual elderly health members, we found this group to be more in public housing, receiving CSSA, and they are living alone, and they are more of them are single. And regarding their help-seeking behavior, they seek help from volunteer or social welfare personnel more than their family members or friends. And they smoke or drink more, and they need more of them need walking aids and have more abnormal IDL and ADL. And their cognitive function is also more impaired. And although they reported the same known incidence of depression, but on our assessment, we found more of them have abnormal geriatric depression scale score. And out of, in 2018, we reviewed this group of referred elders. And of the 76 referred, we have found 261 health problems among them. So one person have multiple health problems. And most of these health problems can be solved at our EHCs. 7.4% of them need some external referrals. Now we have done a survey in total of these group of hard to reach elders, and 69% of them have no family doctor before. And majority of them agree that the service have been beneficial to them. 83.3% of them like the health assessment most. And 81% of them need escort service to come. And many of them will say that they will not come without escort services. And also we survey the NGOs. They found the program beneficial to both the elderly and to the NGO, but the challenges is how to find the right person to come and how to arrange escort for them. And survey of our own medical professionals, they also found that it is beneficial to the clients. They are more concerned about their health, and the home modification and walking aids part can help them. And the clients are feeling much happier when he felt that someone is taking care of them. So in summary, we found that this group of hard to reach elders are older, have a lower education level, and financially more disadvantaged, and have poorer family support. And compared to the sex, age, and education level matched with our EHC members, they have more behavioral risk factors and multiple health problems. And most of this health problem can be managed at EHCs. So in some way, medico-social collaboration is very important. We need the NGOs and the social worker to find the right people for us to offer them service. And but overall, their service utilization is low. And like 20% of them have defaulted the booked appointment of health assessment. After we have referred them to our Ally Health service, many of them cannot complete the course of service, unlike the other EHC members who treasure very much these services. And on subsequent health assessment, they are lower than the usual members. And so we found that this group of patients have poor motivation, and they will not come to our service if there is a lack of escort services. So with our experience, we do echo today's theme that eHealth platform technology and will greatly improve the accessibility of the patients, and this will help aging in place and active aging. Thank you very much.
Thank you very much, Dr. Lee. We can have a discussion after our last speaker, which is Dr. Pamela Tin. She represents a very important think tank, which the government pay attention to. So would you like to share your views on what we're talking about?
Sure. Yes, thank you very much for the invitation, Professor Wu, and thank you for all the panel speakers here today, Dr. Kng, Dr. Lee, and Dr. Choi, for sharing your perspectives. I think we've had a lot of good discussion so far about the happenings, excellent examples of programs that are already in place in the community that reflect good efforts in terms of medical-social collaboration and also integration of care, etc. So as a policy researcher, what I would like to bring to the table to today's discussion is from a policy perspective and from the policy research that my team has been doing at the foundation, how do we perceive medical-social collaboration? And so the slide you see in front of you at the moment is a very core sort of representation of the research that we are doing. This was extracted from a 2018 report that our team put out and really emphasizes our vision of the achieving, for Hong Kong moving towards achieving a primary care-led, a person-centered and integrated healthcare system. And what we mean by integration, of course, there are many different types of integrations we refer to, including medical-social collaboration, but of course, other collaborations such as between the public and private sectors and between the hospital and primary care services. And only do we achieve this, can we actually provide the type of care that each and every Hong Kong citizen will need, because everyone has holistic care, not only just leaning towards medical, clinical needs, but of course, within the society and the community, how can, for example, patients who are discharged from hospital care that are probably deemed to be clinically well, how can they reintegrate into the community? So this is just, this backs up all the thinking and all the research that we've been doing since. And so when I think about medical social collaboration, one of the key statistics that we always like to refer to is avoidable hospital readmission. So that this is also quoted from our 2018 report. And so and it's a study by a Professor Ike and his team that quoted basically approximately 20% of elderly who are discharged from public hospitals are actually readmitted, and these can be avoided if they had better sort of care and support within community settings. And it's important to note that when we refer to community settings, I think that we're not only talking about social care and care provided by NGOs, but it's also the medical care and support, such as primary care that and rehab care, etc., that they receive in the community. So that is a key statistic that I would like to bring forward, because with better collaboration and synergy between the medical and the social sectors, these elderly could have been discharged from the hospital and also supported well in the community that would have avoided their readmission into hospitals. And with this statistic also, a lot of people would then probably think, okay, so it contributes to issues including elderly, for example, within hospitals. They probably would perceive, I'm ready to be discharged, but I probably don't want to be discharged because I know that when I enter back into the community, I'm not sure where I can get that adequate support that I might need, and they worry. And this also contributes to the overburdening of our hospitals. And so it's important to look at that from that perspective. And so I would like to, with integration, I think it's important to emphasize on the importance of synergy. Synergy not just between, of course, like different sectors and disciplines, but synergy between the different levels of a health system. In our research, we always like to refer to taking a look from the policy using a health system perspective. And very often we can broadly categorize a health system into micro, meso, and macro levels. And I would like to just briefly explain my thoughts on each of these levels and have a sort of quick example of efforts, related efforts within each level. And so the first one, as I said, is the micro level. And what we mean by that is really putting people's needs right at the center of our consideration for support and care within the medical and the social system. And so I'm very happy that Dr. Kng quoted this integrated care and discharge support program of the HA previously, because again, when I think of, really trying to better understand the holistic needs of our citizens and each individual, one of the programs that come to mind is definitely this ICDS program that does it quite well because of the Dr. Kng has already talked a bit about it, is about the health assessment and also the formulation of a care plan, a discharge plan, and the coordination between HA and community service providers in how to better support these individuals within community settings. But I'd also like to emphasize that from the community side, of course, apart from the thinking of plans and ways to support the patient and meet the needs, different needs of each of the discharged patients, the support within the community also has consideration for the carers that are a huge support to making sure that needs are met for the patient. And also, apart from the medical and social side of things, also looking at the mental well-being or the emotional support that these patients might need. And of course, this program, there have been numerous studies and many statistics to support the effectiveness of this particular program in terms of lowering the rates of unnecessary and avoidable hospital readmission and attendance at accident and emergency rooms. And so the second level we're talking about is the meso level. And in a nutshell, that's really talking about the service delivery and service provision. And one of the examples I would like to put forward is, for example, we talk about multidisciplinary care teams. And within care teams, there could be medical professionals, of course, such as doctors and nurses, but also we must not forget, for example, social workers, the role of NGOs, etc. These within care teams, we can actually make medical and social collaboration and integration happen. And so one of the examples that come to mind that's also quite relevant to today's theme, which is the role of digital health, is a telehealth project that was conducted by a community center in Sai Kung. And basically what they did, they really wanted to bring primary care to the elderly living in the rural areas in Sai Kung who have difficulties in terms of getting medical care and support that they need in the city and in hospitals. And so what these guys did was they brought care to the elderly. And to make this happen, of course, there was teleconsultation involved, which involved doctors and nurses actually not just meeting these elderly through of course, video conferencing, but also nurses going to support the elderly and their family members with the setup and etc. within their homes. But also the NGOs were involved in the planning and the execution of bringing prescribed medication to the elderly by going to community pharmacies and to buy the medication and bringing it to the elderly. So to me, this is quite a good example of an effort focused on the care and well-being of the elderly that incorporates digital health, but also importantly, in this context, exemplifies the power of having a multidisciplinary care team to provide support. And finally, at the macro level, in essence, what we are talking about and refer to is having an overall sort of governance structure and a key strategy and vision for what we want to achieve in terms of medical and social integration. And this can be through many things, such as strategic documents. For example, as Dr. Choi had talked about, the government's dedication to developing primary healthcare. There's going to be a blueprint, the dedication towards implementing district health centers, etc. This is all the dedication of the government, and there are going to be implementation plans and strategic plans in how to deliver this. But also one of the things that came to my mind when we talk about the macro level and medical social collaboration is the effort in Singapore, for which they had set up an AIC, so Agency for Integrated Care. This particular arm is actually the key role is as a national care integrator, but specifically they coordinate the delivery of aged care services. And so basically they serve a range of seniors from healthy to disabled to bedbound, and they try to coordinate, understand the needs of these of the different elderly and also their caregivers, and try to provide the necessary assistance in terms of financial, caregiver support, body and mind, different services that you can think of. And so they really try to mobilize all the resources in the community to facilitate the care of the elderly. And the power of this, having such a agency put in place, is really to oversee the overall process of integration and also to implement it. So I think I'll stop here, but before I do, I have one more key example here. In this photo, you can see that it's actually a sort of volunteer visit to the elderly in Hong Kong for promoting vaccination uptake. But what I want to bring your attention to is, if you can see, like in the actual home, you can see a chair, and behind that there's a bunch of papers sort of like stuck onto the wall of the home of this elderly. And what the papers really were for the different notes for the elderly to remind the particular individual what sort of medical services they could use in their community and what sort of social services they could use in the community, all to really remind them that this is where they can find help and support when they need it, and effectively using that elderly as the integrator of medical and social care. So what I'm saying, and I want the message I want to convey is, apart from using, of course, that individual as the care integrator, we also need to look at how the health system in the micro, meso, and macro level can support the overall integration of social and medical integration in Hong Kong. So I think I'll stop here, and I look forward to the discussion. Thank you.
Yeah, thank you very much, Pamela. Just to follow on your story about Sai Kung, I think that project was also a very good example of how enterprising NGOs can be, and also to make use of social capital. Because Sai Kung, a lot of people go there for hiking during the weekends. And my understanding is that they ask the hikers to be volunteers. So when they climb up whatever remote hillside, to drop in on whoever and to check their blood pressure or something. So this is a really very imaginative use of social capital. Perhaps I could just look at the overview. I mean, there's so many good things going on in Hong Kong with regard to elderly services, and I think a useful way is to think of a slope. When you're about 50, 60, you're still okay, but you have to maintain your function down to the end of life, if you like, in a slope in terms of dependency. And that is why we have so many services. We have different services targeted different stages, where the prime responsibility is targeted towards specific stages. So obviously HA is all the bad things, all the negative things. And the NGOs perhaps will be the more upstream. And to accompany that, you have different assessment tools, simple screening down to very complicated screening. And then we have the addition of technology, how this can fit in. And I think this is a very useful concept, how we can bring everything together. So, for example, various speakers mentioned person-centered and technology. Now, I think it seems that the best way to motivate people is to have them look to care about their health, right, to understand. And so this is the person-centered thing. And I think that technology is very useful in focusing their mind. You know, they know where they're at. So in that sense, an app would be very useful, or something similar that they can check on. So if you look at the HA Go, it's an app. So the person or their relative can find out what's going on. To me, that is a very empowering kind of technology. What about the other app? The other HA app is the Yigin Tong. The Yigin Tong. Now that's very helpful because it tells you what vaccination you have, what drugs you're taking, among other things. And I had vaccination, and they installed it for me because I was not competent enough to install that thing. but what I found is when I check drugs, it says that I was on many drugs. And I thought that must be a mistake. Then I discovered that I was admitted to a hospital some time ago. So I could, those drugs were actually what I was given while I was in hospital. So I know, and whatever service provider I come into contact with, they will also know. So I think the app is a much better way, apps a much better way to develop than like electronic health record in a sense, because that sharing between different institutions and they have their own barriers. But outside the health sector, for example, we mentioned the Elderly Health Center want to reach out to vulnerable people, and that's very important because they don't know how to go to get services. And what is the role of technology there? Apparently, the housing authority has a system, very sophisticated system, where they can, for every housing estate they manage, there are units that light up, and these are units that are occupied by people, old people living alone. So they have this knowledge, and so a lot of NGOs want to access these things. I'm sure anybody providing elderly care service would want to. So the technology is there, but there's a barrier in imparting that information. Now, if you were driving a vaccination program, you don't have to go to these lockdown estates to check. You see, you can just get hold of that list and just visit these people. So I think with technology, we can do a lot of things, but it's just a question of removing barriers. Would each of you like to say something about how you would view the future development, given that there's a primary care blueprint developing, and you see everything is developing. We're not staying still. How would you see the future development in terms of feasibility? You know, government support, health literacy, resource constraints, and so on. This perfect vision that Pamela Tin kind of listed out. I mean, is it ever possible? I noticed she advocated another authority, another. Yeah, but I agree. I mean, there should be some coordination. We need to navigate. I mean, if I, as a user, I listen to this symposium, I'm greatly excited by all the services, but I wouldn't know how to navigate. But I wouldn't go around like checking these out like shopping. I mean, I would only need to do it when something happens to me, and that depends on what happens to me. I mean, if we use that kind of thinking, would you all like to have one last word? Perhaps Dr. Kng can start.
It's hard to project in the future, but I think that perhaps in Hong Kong, my difficulty is that even though there are many private, let's say the primary care landscape is dominated by GPs, private GPs, and a lot of NGOs, and the coordination of all these GPs and the NGOs to me is still very, you know, I mean, taking reference to what Pamela said about the A1 AIC in Singapore, I think there needs to be something like that to coordinate different NGOs as to how they're going to support perhaps elderly. Okay, so I believe that the DHC is supposed to do that, but whether that is a role that is really too heavy or what structures do they need to enable them to do that, I think probably Cissy will be the best person to comment. Yeah. But for me, I think we need coordination.
Yeah, your comment, please, Dr. Choi.
Yes, I'm sure this is the one of the very key roles of the district health center. But I think integration is not that easy. It's easier said than done. because actually talking about integration, there are different components of integration, I think, including the types of integration. You're talking about the organization level, professional level, cultural, technical, and also the process and the breadth and the depth, especially and as well as the intensity, because are we talking about the whole population group or a specific target group? Is it a continuum that spans throughout using an informal way or very structured policy level, meso level type of integration? I think we still have a long way to go, but I think the direction is there. We are starting there. And this is a quite new model in Hong Kong. You have to break through all the policy and cultural differences to come together to have the integration. We are starting towards that angle. In particular, we have to first align everybody to have the same vision and the same goal, as well as putting some incentive for them. The incentive can be not financial, can be any other things that we can incentive the people to work hand in hand towards that direction. I think in particular, Carolyn is here, and you mentioned about the DHC. I'm quite positive that there's some districts or some unit or some groups are more favor this kind of collaboration, and some people are more against it or reluctant to change, etc. So when maybe we can start with those more passionate and more willing and have the same vision towards that level. We try to work out some successful model first. Then we can try to convince other people and other districts, slowly roll it out, and then we can have a very comprehensive and the more involvement of different parties towards that end. But I think that end is never ending, because integrated is talking about level, so we can always improve better and better. Even the IDSP that you mentioned is a start, but the scale and scope is still limited to a limited type of clients. How we can roll it out, expand it to the other elderlies, for example, you said the frail one, and then all elderlies, and even integrated care for all people. I think it's not only elderly, although the discussion here today is about older people, but I think integrated care should be applied to every level, every people with health issues. So let's work together towards that direction.
Yeah. Thank you, and good luck with the development of the DHCs. Pilot programs are essential, right? I think that's the way to go. So Dr. Lee's pilot program, I think, is very worthwhile in trying to identify the vulnerable. So may I ask, since it's a government pilot program, are we looking at in future that it might become regularized, like the daycare voucher and other things like that? Might become a recurring program?
Yeah. You see that all my data ends at 2020, and in the past 2 years, many of our colleagues have been deployed to fight the COVID, and we have EHC have actually scaled down, and we have just started to resume service this month, and I very much look forward to the more resumption of this pilot program.
Yeah, maybe you can have a word with the housing authority.
They are our collaborators as well.
Oh, good. Right. So yeah, Pamela, do you want to say some final words?
Yeah, sure. I think I agree with what other panelists have discussed. And also, I think one of the important aspects is really for us to empower our citizens, so that, like Professor Wu, you talked about the health literacy, you mentioned it just now. I think with all that's going on, regardless of at the macro, sort of the governance level or at the service delivery level, when we try to do integration, it's important that our citizens understand how to navigate the entire system and where to get their needs, where to get the services to meet the needs. And to do that, for example, when we promote primary care in community settings, it's important for us to first make citizens understand the importance of primary care. I understand a lot of work is being done promotion, but also like one of the things is we need to make sure that our citizens understand and also are able to navigate through this system. And by integrating all these services, and when we talk about integration, what we essentially hope to achieve in the end is so that these people can get a better care experience. And so I think it's important that the citizens keep informed, and it might be exactly through that app that Professor Wu was talking about.
Yeah, right. So I think we've run out of time. I'd just like to thank you all very much for spending some time in talking about this issue. And I hope we can continue to work together in some form in future. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you, Professor Wu, Dr. Choi, Dr. Kng, Dr.